Hello, dear students. My full name is Nabiyeva Diora Mirhamzavina. Um, I'm an assistant of the first pediatrics and neonatology department, Samarkand State Medical University. So, your today's topic is pediatric hypertension. In other words, hypertension of in the children. Okay, objectives. The importance of diagnosing hypertension in childhood, the definition of childhood hypertension, clinical presentation of childhood hypertension, causes, diagnostic workup, evolution of associated risk factors for cardiovascular disease, evaluation of end organ damage, and approach to the treatment. Hypertension in childhood and adolescence. So, prevalence of clinical hypertension, overweight, obesity, 24%, skip disordered breathing, 14%, preterm birth, 7.3%, serious health problem, and underdiagnosed. Importance of diagnosing hypertension in children. Well, established that hypertension in adults is associated with high risk factors for cardiovascular disease. Some evidence of association between hypertension and atherosclerosis in children and adolescents. Patients with hypertension, especially obese, may have additional risk factors, hyperlipidemia, diabetes, for cardiovascular disease. And you should know about previous definition of hypertension. Normal blood pressure is systolic and diastolic, less than 90% for age, gender. So pre-hypertension, systolic or diastolic, 90 and 95%. Stage first hypertension, systolic or diastolic, more than 95%, 99% in adolescents. In adolescents, more than 120 to 80. So stage first hypertension, systolic or diastolic, more than 99%. At least three abnormal readings or on separate occasions. Well, when should blood pressure be measured? So, the American Academy of Pediatrics advise blood pressure should be measured annually in children and adolescents more than 3 years of age. Blood pressure should be checked in all children, adolescents more than 3 years of age, and at every health encounter if they have obesity, are taking medications known to increase blood pressure, or BP. You can name have renal disease, a history of aortic arch obstruction or coarctation, or diabetes. So, guidelines for measurement of blood pressure. Quiet for 3-5 minutes. Sitting back, supported feet uncrossed on floor. Right arm at heart level, supported uncovered above the cuff. Lower end of cuff 2 or 3 centimeters above antecubital fossa. Auscultation preferred, or at least add to confirm. Bladder with at least 40% of arm circumference, and to measure blood pressure in legs, patient prone, cuff placed midnight. It is pictures for guidelines for measurement of blood pressure. So, patient management on the basis of office blood pressure. Stage first, hypertension. Initial visit. If patient asymptomatic, lifestyle, counseling, and reach blood pressure in 1 to 2 weeks by auscultation. Second visit, if blood pressure reading still at stage first level, check upper and the lower extremity blood pressure, both arms, one leg, nutrition and or weight management, referral, blood pressure reached in 3 months by auscultation. And third visit, if blood pressure reading continues to be at stage first level after 3 visits. So diagnostic evolution, subspecialty referral, and treatment should be initiated. Okay, ambulatory blood pressure monitoring. It is not the same as a home blood pressure machine and is similar to a Holter monitor. Also, you should know about underdiagnosis of hypertension in children. 3.5% of children have hypertension by definition. Cohort of 187 children and adolescents observed 3 times at well-check visits in a large academic outpatient urban clinic. 507 or 3.6% had hypertension on more than 3 measurements. And last one, only 131, 26% had documented hypertension or pre-hypertension diagnosis in the charts. So, diagnosis of hypertension in children. Masked hypertension, normal office blood pressure, but elevated blood pressure on ABPM, found in 5.8% of unselected children studied by ABPM. At risk patients for patients with obesity, secondary forms of hypertension, increased risk for end organ hypertensive damage. So, clinical presentation, manifestations. First one is asymptomatic, incidental on routine exam. Symptomatic includes cardiac, palpitations, murmur, in the heart, in the auscultation, central nervous system, headache, vomiting, lethargy, seizures, blurred vision, confusion, and facial palsy. And last one is poor feeding, failure to thrive infants. Also, continue clinical presentation, signs and symptoms of another disease, color urine of glomerulonephritis, facial swelling of nephritis, renal failure, Cushingoid appearance, virilization, and last one, signs of thyrotoxicosis. Okay, approach to the treatment of hypertension. Non-pharmacological, weight loss when hypertension is associated with obesity, diet reducing sodium intake to 1.5 grams in one day, increasing fruit and vegetables, low-fat dairy products, increasing dynamic exercise, avoid static exercise, weight lifting, limiting sedentary activity to 2 hours in one day. Okay, pharmacological treatment of hypertension start with one drug and increase gradually to maximum. If inadequate control, add another drug. First line medication is AC, EI, ARB, long-acting calcium channel blockers or thiazides. To improve compliance 1 or 2 in one day, drug with least side effects. For severe symptomatic hypertension, admit and treat with force medications. Summary. Hypertension is a common health problem in children. Blood pressure should be checked starting at age 3 years. Normal blood pressure distribution tables should be used to diagnose hypertension. Workup should be guided based on risk factors. Most causes of secondary childhood hypertension are kidney related. Target organ damage needs to be evaluated. So treatment should start with non-pharmacological measures and then medications added if needed. And last one is monitor BP, control adherence, target organ effects. So thank you for your attention. It is the end.